Okay, good afternoon, everyone. So let's start the class for today. We have already started the discussion on hypertension and hypertensive heart disease. So let's continue. In the beginning, we must know what is hypertension. So let's define it once again. Hypertension is a sustained increase in systolic pressure or diastolic pressure by more than 140 and 90. That is a sustained release. So once or twice measurement is not enough. Okay, probably we can monitor this patient for a bit of time and repeat it again. If consistent rise in blood pressure more than 140 systolic and 90 diastolic is shown, then this is defined as hypertension. Or along with that, if signs and symptoms are there, then it will even aid in the diagnosis. This is a very common disorder all over the world, very common these days, probably because of the increased incidence of obesity. The hypertension is also increasing day by day. Another is sedentary lifestyle will also cause rise in hypertension. There are two types: idiopathic or essential or primary hypertension. All of these are synonymous term, which is overwhelming majority, 95% of the time this is the cause, and rest 5% of the time secondary hypertension is the cause. And this secondary hypertension means we have certain non causes. We know, okay, what are the causes there. Now, another classification of hypertension is benign and malignant hypertension. Now, we were talking this in the morning. Benign hypertension accounts for 95% of the cases of hypertension. So this is again very common. This is a good point in comparison to malignant hypertension, because malignant by the term itself suggests a lot of target organs would be damaged there. In this condition, there is mild to moderate elevation in blood pressure. Usually, the diastolic blood pressure would remain lesser than 120. This is many of the time this is asymptomatic and silent disease. It doesn't produce many sign and symptom. That's why asymptomatic or silent condition. Over a long period of time, if the blood pressure is not controlled, then multiple body organs are affected. And in the morning also, I clearly told you there are 4 target organs for hypertensive damage. Okay, 4 target organs for hypertensive damage. They are brain, eye, heart, and kidney. Okay, multiple blood vessels are also damaged there. Actually, blood inside the blood vessels there is formation of atherosclerosis, and not only these organs, so many others can also be affected if that is the problem. But those 4 are the major one. Regarding the microscopic appearance, if we take a biopsy from the blood vessels, they have developed hyaline arteriolosclerosis, especially the arterioles of the blood vessel. Okay? They get sclerosed or they get thickened, and there is a deposition of pink substance that is known as hyaline appearance in case of histopathology. When we stain by hematoxylin and eosin, it looks pink. Now, the last part is very important one. This benign hypertension can cause a lot of this damage. Concentric left ventricular hypertrophy in the heart. That means the wall of the left ventricle is thickened, and this thickness is towards the chamber or the lumen, so that the diameter of the chamber or lumen is decreased, which leads to problem during diastolic refilling phase. So there is development of the back pressure, and it can lead to pulmonary edema. Congestive cardiac failure, very common feature. Accelerated atherosclerosis, because we have studied atheroma is mainly caused by caused by 4 important risk factors like diabetes, hypertension, smoking, and hyperlipidemia. So out of those 4, this hypertension is one of them. Myocardial infarction, it is related to atherosclerosis. Aneurysm formation, rupture, and dissection of aorta, again very common in the presence of hypertension, because inside the blood vessel the pressure is high. That pressure is always felt by the wall of the blood vessel, especially artery, and it can develop all these problems. Intracerebral hemorrhage, a type of stroke, we call it hemorrhagic stroke. Hypertension is a major risk factor for that. And chronic hypertension can also lead to kidney failure. Okay, so these are some of the very important point. That's why if blood pressure is high in a patient, it should be controlled. It should be controlled. There are different way how to control it. One is with the help of medicine, another physical exercise. Okay, physical exercise and relaxation activity. Now see here, these are the morphology of hypertensive vascular disease. Means inside the blood vessel what's going on. This one, okay, this is A, so it is clearly written, this is hyaline arteriolosclerosis. The arteriolar wall is thickened with the deposition of amorphous proteinaceous material. This is known as hyalinized or hyaline substance is deposited on the wall. See here, look at the lumen, it is narrowed now, the wall is getting thicker. Okay, this is a typical appearance. Whereas in case of malignant hypertension, hyperplastic arteriolosclerosis is seen. This hyperplastic arteriolosclerosis is also known as onion skinning or onion skin like appearance. See there, this is layer by layer thickening, layer by layer. Okay, so ultimately it will also cause a decrease in the lumen size. So this is in malignant hypertension. The first one is in benign hypertension. This is a very important point and can be asked in an MCQ exam as well. Now let's talk about malignant hypertension. It accounts for just 5% of the cases of hypertension, so less common than benign. And according to the definition, the blood pressure is extremely high. Now look here, the diastolic blood pressure is more than 120 millimeter mercury, which cause end organ damage. The systolic blood pressure value is not mentioned here, but if diastolic is so high, systolic is also usually very high, probably more than 220, okay, or 240 like that. But it is not a part of the definition, so you don't need to mention that. But usually it is also very high. Now, what is the danger? If blood pressure is so high, it can easily cause end organ or target organ damage. So I already talked about those target organ. Okay, heart, brain, kidney, and retina. So when we do fundoscopic exam, this fundoscopic examination is the examination of retina by a special instrument which is called ophthalmoscope or fundoscope. So when we examine the eye with this, we can see retinal hemorrhage and exudate. Retinal hemorrhage and exudate. See here. This hemorrhage is because of the rupture of small blood vessels there, and exudation is leakage of the protein-rich fluid. And one very important point is there is papilledema. Now papilledema is, okay, bulging of optic disc. Okay, bulging of optic disc, or you can also say edema of optic disc. Now optic disc is the head of the optic nerve. That's how we remember. In case of raise ICP, raise intracranial pressure, that pressure is reflected on the optic nerve because it is also surrounded by the meninges, and that pressure is reflected on the head of the optic nerve. That's why it is swollen, which is known as papilledema. Now you may be wondering, what is the connection between raised ICP and malignant hypertension? Now the answer is very simple. Malignant hypertension is severely rise in blood pressure, and one of the end organ here is brain. So brain is suffering because of this high blood pressure. Brain can suffer from cerebral edema that can give rise to raised ICP, and that is giving papilledema. Look at the connection there, one after other. Okay, this is very important point. Now, when we examine the kidney in the grossly, what we see there, kidney has flea-bitten appearance. On the surface, it looks like kidney has flea-bitten appearance. Flea is a small insect, isn't it? Small insect. If it bites a human being on the skin, a small red spots are seen. The same type of comparison we are doing here. Flea-bitten appearance, and that is because of the petechial hemorrhage on the surface of the kidney. On the microscopic examination, hyperplastic arteriolosclerosis or onion skin-like appearance is seen on the wall of the blood vessels. This is quite important point. Just now we have seen that picture. And necrotizing arteriolitis is also occurring. That means fibrinoid necrosis of the vessel wall. That is not very common in comparison to onion skin-like appearance. This malignant type of hypertension is a medical emergency. It's a medical emergency because if such a high blood pressure is not treated in time, patient may die because of different complication. The one of the important complication is intracerebral hemorrhage. See, look at the blood pressure here. It can easily cause rupture of a small blood vessel inside the brain, and the patient will go into coma. Okay, this is hemorrhagic type of stroke. Another one, patient may die within 2 years from renal failure or even heart failure. So we must go for the treatment, and there are so many important drugs for the reduction of blood pressure. So many. Okay, we'll talk about that later on towards the end of the topic. I'll ask this question to you guys. Now let's move on. Okay, what are the types of hypertension? Now these types, okay, in the beginning of the class we already talked about essential hypertension, also known as idiopathic hypertension or primary hypertension, which is present in 95% of the cases of hypertension, and secondary hypertension is only 5%. Now we know the cause of secondary hypertension, and these may be renal disorders, cardiovascular disorders, endocrine disorders, and neurological disorders. Even drugs are responsible there. Now let's find out the causes one after other. In the renal diseases or disorders, we have acute glomerulonephritis. Acute glomerulonephritis. Now, acute glomerulonephritis, okay, uh, causes acute nephritic syndrome in the kidney. Acute nephritic syndrome in the kidney. That means there is a slight amount of proteinuria, there is hematuria, there is hypertension, and there is edema. Okay, this is acute glomerulonephritis. Hypertension is a part of that. Chronic renal disease. Chronic renal disease means one of the perfect example here is chronic renal failure, CRF. Hypertension is always a part of chronic renal failure. Without hypertension, we will doubt our diagnosis of chronic renal failure. So this is very important point. And the other hand, the opposite thing is also true. Chronic hypertension for a long time result in chronic renal failure also. That is also true. Polycystic disease of the kidney. Okay. In adult, there is one common disorders which is called adult polycystic kidney disease, autosomal dominant variety, that can easily cause hypertension. Hypertension is one of the commonest manifestation of that. Renal artery stenosis. Now think about renal artery. Renal artery is the only artery which takes blood to the kidney. If it is narrowed, okay, somehow if it is very narrow, then less amount of blood will go into the kidney. Now it will clearly leads to activation of renin angiotensin aldosterone system, and that will lead to raise in blood pressure. That is the connection. Renal vasculitis, again it is making the blood vessel narrow, and renin producing tumor. Very easy. Renin is a part of renin angiotensin aldosterone system. If renin is high, of course the end product aldosterone and angiotensin 2, they are also high, so they will lead to raise in blood pressure. So everything we can explain here. So let me wrap up this with one sentence. Any type of kidney disease that has a real good chance of raising blood pressure, any. Okay. Now, the second important types of causes are endocrine disorders. Endocrine disorders. Okay. So please pay attention here. Probably many of these things are new for you. Now, regarding the endocrine disorders, okay, so many different causes are there, like adrenocortical hyperfunction. Now, adrenal gland or suprarenal gland has two parts, cortex and medulla. Now, medulla is secreting catecholamine. Okay, medulla is secreting catecholamine. If that catecholamine is excessive in the circulation, it itself can lead to hypertension. There is a disease which is known as pheochromocytoma. You can see it right here. Pheochromocytoma. This is a tumor which develops in adrenal medulla, and this tumor is producing catecholamine. That means epinephrine and norepinephrine. So there is a high chance of blood pressure here. Pheochromocytoma. Okay. Now let's go to the outer part of this adrenal gland, that is called cortex. Three important hormones are released by the adrenal cortex. One is mineralocorticoid, second glucocorticoid, and third is sex steroid. If glucocorticoid is high, okay, if glucocorticoid is high, we call that Cushing syndrome. Okay, hypertension is a part of Cushing syndrome. I'll explain to you why a little bit later. Another condition is primary aldosteronism. Now look at the term aldosterone. This aldosterone is a mineralocorticoid. So there must be a tumor which produces mineralocorticoid or hyperplasia of that area which is producing excessive mineralocorticoid. These are called primary disorders. And this term, we have another term for this. This is also known as Cohn syndrome. Okay, Cohn syndrome. So let me write it here for you. Cohn syndrome is primary hyperaldosteronism. Now, both of these, Cushing syndrome and Cohn syndrome, now one is having excessive glucocorticoid, another is having excessive mineralocorticoid, but both of them had the ability to retain sodium and water. The main function of aldosterone is that only. You have studied already, isn't it? It retains sodium and water in the body. But even the glucocorticoid like cortisol is having that function. So both of them can lead to rise in blood pressure. Another is congenital adrenal hyperplasia. Now this is another very interesting condition where mineralocorticoid, okay, and glucocorticoid are not formed. Rather than that, sex steroid is formed in increased amount. Those sex steroid are known as androgen, and whenever androgen is also high, it can also cause increase in blood pressure. At the same time, there are certain other enzyme deficiency, okay, like 11 beta hydroxylase, 3 beta hydroxysteroid deficiency. All these things are there. So during that time, some other type of mineralocorticoids are formed, not aldosterone. Aldosterone is the main mineralocorticoid, but some other type of mineralocorticoids are formed because of abnormal metabolic pathway, and they can also retain some amount of fluid and water. So you can explain hypertension like that as well. Let's move to some other causes now. Exogenous hormone. If we give exogenous hormone, now exogenous means from outside, like glucocorticoid. Okay, you also call it corticosteroid. They are one of the commonest drug which is used in clinical practice, like prednisolone, dexamethasone, betamethasone, budesonide, beclomethasone, isn't it? So many are there. Estrogen, okay, This estrogen is mainly present in oral contraceptive pill, OCP, oral contraceptive pill. Another one, sympathomimetic drug, okay, sympathomimetic drug, and tyramine containing food with monoamine oxidase inhibitor. Now it needs a little bit of explanation, so listen carefully. Now oral contraceptive pill, definitely it will cause raise in blood pressure because of estrogen content. Okay, this is very easy. But sympathomimetic drug means these drugs are similar to the effect which is created by epinephrine, or you can also say sympathetic nervous system, okay, is stimulated by this drug, and that's how they cause increase in blood pressure. So many important example we can give here, like dopamine, dobutamine, okay, then a related type of drugs, so many are there, like phenylephrine, isn't it, different drugs. And tyramine containing food with monoamine oxidase inhibitor, this is a very important point. I'm not sure whether you have studied this or not. In case of antidepressant drug, this monoamine oxidase inhibitor is an antidepressant medicine. If we give this drug uh, uh, along with this tyramine containing food, okay, now what will happen, this tyramine, okay, tyramine will cause release of norepinephrine from the synaptic junction or the synaptic vesicle, you can say. Tyramine will lead to release of norepinephrine from synaptic vesicle. Now that norepinephrine is an important type of uh, catecholamine, isn't it? Catecholamine. So this monoamine oxidase, okay, is the enzyme which is metabolizing that catecholamine. So what is going on here now? This monoamine oxidase would be inhibited by the drug which the patient is taking. That's the first thing. So that norepinephrine cannot be metabolized, and it is a very powerful catecholamine. So it can easily lead to rapidly high blood pressure, and this patient may have a lot of complication. So we always suggest this: do not give tyramine containing food like cheese. Okay, cheese is one of the important example, and wine is another one with monoamine oxidase inhibitor. Phenelzine and tranylcypromine are monoamine oxidase inhibitor drug. Now acromegaly, okay, acromegaly is another disease. Now acromegaly, anybody know what is acromegaly? Yes, probably somebody have heard this term before.
Yes, sir, I know, sir.
Yes, please.
Sir, acromegaly is when the excessive somatotrophin is there in the body. Sir, somatotrophin is a growth hormone. So, sir, when it is increased, so sir, there is the so sir, the hand and the fingers get bigger. So, sir, this is the main symptom of it.
Okay, good. Your answer is absolutely correct, Uzair. So in acromegaly, please listen, other students, listen here, okay? In acromegaly, the growth hormone is excessive after the fusion of epiphysis. Now, after the epiphysis is fused, I mean in adults who are fully grown, they can't be taller anymore, but the body sizes, the organ sizes will increase. So the hand size will increase, the face size will increase, nose, tongue, internal organ, everything is increasing. And one of the important manifestation is hypertension as well. Okay, hypothyroidism or myxedema, because of the deposition of mucopolysaccharide like substance, okay, everywhere. So there is increased peripheral resistance in case of hypothyroidism, which causes rise in blood pressure. Whereas hyperthyroidism or thyrotoxicosis is excessive thyroid hormone level condition. So it will cause increase in cardiac output, it will cause activation of sympathetic nervous system, and that is increasing the blood pressure. Pregnancy is an important condition. It is a in this condition there are a lot of hormones, especially female hormones, and they are increasing the blood pressure. So very important part in the exam, we love to ask Can you tell me the endocrine causes of hypertension? So students should take this name. Now, what are the cardiovascular causes of secondary hypertension? Now, look at the causes here. Coarctation of aorta. This is a congenital problem. Okay, it is a type of congenital heart disease. In this condition, the aorta is acutely narrowed in some area. Okay, that area is very near to the ligamentum arteriosum, or from where the subclavian artery originates. Sometimes it is preductal, sometimes it is postductal. Now, in coarctation of the aorta, okay, because of that typical location of the narrowness or narrowing of aorta, the blood pressure is high only in the upper limb and head and neck region, but in the lower limb or lower part of the body, blood pressure is not high. Always remember this important point. That's why there is a chance of damage in the brain and head and neck area because of high blood pressure rather than in other part of the body. And one of the important diagnostic point in coarctation of the aorta, okay, is called radiofemoral delay. Radiofemoral delay. Let me write this for you. Now, what do you mean by that? When we palpate both radial pulse and femoral pulse at the same time, because of this acute constriction of aorta, very little amount of blood is flowing towards the femoral artery, but radial artery is quite normal. So what does that mean now? I can feel radial pulse slightly ahead the femoral pulse. So this is called radiofemoral delay. And this is a very important question your teacher is going to ask you. Now, another one is polyarteritis nodosa or other type of vasculitic disorder. Any type of vasculitic disorder can lead to hypertension because they cause inflammation on the wall of the blood vessel, which will make the lumen narrow, and this will cause increased peripheral resistance. Increase intravascular volume. Now the blood volume itself is high. Increase in blood volume causes increase in cardiac output. Increase in cardiac output causes increase in blood pressure. That is the connection. See here, increased cardiac output itself, these are called hyperdynamic circulation. All of them can have slightly higher blood pressure. And rigidity of the aorta. In older age, this can easily occur. Aorta can become rigid, it will increase the peripheral resistance and can lead to increase in blood pressure. Now, neurologic diseases can also lead to high in blood pressure. They are psychogenic. Okay, psychogenic means these are the neurotic people. Neurotic people means they take a lot of stress in everything. Even if the problem is very mild one, they show a lot of reaction to that. That is a nature. That is a difference in nature between people. Some people are very calm and cool. Even if the situation is very adverse, they say, yes, nothing will happen, we can manage it. Okay. But some other, okay, they keep running here and there, and those type of people will definitely have higher blood pressure than the other one. Raise intracranial pressure, very important cause of hypertension, very, very important cause. So there are so many diseases I can list which can give rise to increased intracranial pressure. Now they are called space occupying lesion inside the cranial cavity, like brain tumor, brain abscess, any clot formation inside the brain, okay, like a hematoma, tuberculoma, okay, this is a part of tubercular meningitis, neurocysticercosis, this is a tapeworm which can go into the brain and can cause the problem. So these are the space occupying lesion. Others are infection inside the brain like meningitis, encephalitis, cerebral malaria, okay, or even brain abscess can be included here. Hydrocephalus, when the CSF pathway is blocked, it can again lead to very high intracranial pressure. See there, this is the way you have to answer. Okay, very common question. Now, in case of raised ICP, we have got one important triad here, which is called Cushing triad. Okay, so let me write the 3 points of Cushing triad. They are called hypertension. That's why we are talking it right now. Hypertension, then bradycardia, okay, and irregular breathing. It leads to irregular breathing or irregular respiration. This is called Cushing's triad. So don't forget that. Another is sleep apnea or obstructive sleep apnea. And during this obstructive type of sleep apnea, patient snore a lot. And there is one moment when the patient suddenly wakes up from the sleep because of hypoxia. Okay, and if this process goes on for a longer time, there will be, hypoxic changes which start to appear in the patient's body. So this hypoxic change is responsible for this type of, raise in blood pressure. There's so many, associated changes will occur now. Okay, this is not that easy mechanism actually. If a person cannot sleep well at night, okay, the person becomes stressful the whole day. Okay, the whole daytime the person do not have that enthusiasm to work. Sleep is very, very important for us. So all related things are there. Another is acute stress, including surgery. Acute stress can occur from so many different things, isn't it? For the student, stress is during exam time. Stress is when you wake up in the early morning to come to the class. Sometimes that is a stress for the student. Now I can give example right now. For so many of the students, coming to this live online class is a stress. Okay, so stress can occur to anyone. Different types are there, and if we cannot cope up with that stress, then blood pressure may be high. Surgery is definitely a stress. All of us are scared of surgery. Even we are doctor or medical student, we are also scared because we know what's going on there. Okay, so stressful situation is a cause of hypertension. That's why during the management of hypertension, please remember this, relaxation activity is one of the treatment part. Relaxation activity, you should relax yourself, and that is considered one of the major treatment part of hypertension. Now with this, let's talk about this slide, which is telling us how blood pressure is regulated inside our body. A bit of physiology now. Okay, see here. Now let me start with the meaning itself. Blood pressure is equal to cardiac output multiplied by peripheral resistance. I'm sure everybody know that. Cardiac output multiplied by peripheral resistance. Now if cardiac output is high or more, and if peripheral resistance is also more, blood pressure will be definitely be more or high. Now what are those factors which increases the cardiac output? They are heart rate and cardiac contractility. If heart rate is high or faster, and if heart is contracting more, then definitely cardiac output will be more, because cardiac output is equivalent to heart rate multiplied by stroke volume. The heart rate is already written here. This contractility will increase the stroke volume, so cardiac output would be higher, and it will cause increase in blood pressure. Another one is a blood volume. Okay, blood volume itself. Excessive sodium containing diet, excessive level of mineralocorticoids like aldosterone in the body, and even the atriopeptine. Okay, now this atriopeptine actually is regulating it. Okay, atriopeptine means sodium natriuretic peptide. Okay, or you can simply say natriuretic peptide as well. Atrial natriuretic peptide, it has got a different name. So what is the function of this? Natriuresis. It will decrease the amount of sodium in the blood. So if the level of this atriopeptine, okay, is less, so what does that mean? Okay, more sodium will be accumulated in the body. So a lot of these things are related with each other. Now let's go to the peripheral resistance part. There are some local factors which are involved in autoregulation, like pH and hypoxia. Okay, pH and hypoxia. There are some neural factors which are known as vasoconstrictor or vasodilator. One of the important example is alpha 1 adrenergic receptors is vasoconstrictor, whereas beta adrenergic receptors are vasodilator. So beta 2, importantly are beta 2 here. Every student know that. If we stimulate beta 2, there will be vasodilation. If we stimulate alpha 1, there will be vasoconstriction. Okay, so they are maintaining the peripheral resistance. Others are the humoral factors like angiotensin 2, catecholamine, thromboxane A2, leukotrienes, and endothelin. All of these are vasoconstrictor, whereas prostaglandins, okay, bradykinin, and nitric oxide, they are the vasodilator. So let me tell you one sentence so it will be very easy for you. There should be the balance between all these factors in our body, then only there will be good homeostasis. If one thing is more than the other, okay, then it will be pathological. Now in this condition, if constrictors are more than dilators, okay, there will be definitely raise in blood pressure. If blood volume is high, if heart is working more, there is increase in blood pressure. So everything should be in balance for the normal blood pressure in the body. Okay, so let's proceed further. We're talking about regulation of blood pressure inside the body. Now we already talked about there should be a good balance for the regulation of blood pressure between vasoconstrictors and vasodilators and so many other factors as well. So this is the summary. Blood pressure is determined by vascular resistance and cardiac output. Vascular resistance is regulated at the level of the arterioles, which is influenced by neural and hormonal input. So it is influenced by neural and hormonal input. So what do you mean by that? Hormonal means all those different hormones or humoral, mechanism which we discussed, like angiotensin 2, isn't it? Endothelin, and all different examples are there. Okay. Cardiac output is determined by heart rate and stroke volume, which is strongly influenced by blood volume. Blood volume in turn is regulated mainly by renal sodium excretion or resorption. And this is the job of aldosterone. So everything is connected with each other. Now, though many students know this, but we are still repeating it so that everybody would be crystal clear. And when we ask these questions, we expect answer from the student, okay? Otherwise, it will give a very bad impression. Now, renin is a major regulator of blood pressure. How? That's the question. It is secreted by the kidney in response to decreased blood pressure in afferent arteriole. Now, that can happen if there is hypovolemia or hypotension, when there is decreased perfusion of the kidney in the region of afferent arteriole, then renin would be released. This renin cleaves angiotensin to angiotensin 1, and this angiotensin 1 would be converted into 2, okay, mainly inside the capillaries of the lung by ACE enzyme, angiotensin converting enzyme. So this is very important point. This angiotensin 2 is a powerful substance. Okay? It is a very powerful substance. So it is regulating blood pressure by increasing the vascular smooth muscle tone and by increasing adrenal aldosterone secretion and consequently renal sodium resorption. So this angiotensin itself is a powerful vasoconstrictor. At the same time, it is causing release of aldosterone from the adrenal cortex and that aldosterone is retaining sodium and water from the nephron or from the kidney. So that will help the blood pressure to come back towards the normal. So this is one of the major part of compensatory mechanisms of our body. Okay, now let's discuss about this slide. This slide is talking all those things which I just mentioned here. This is the interplay of renin, angiotensin, aldosterone, and atrial natriuretic peptide in the blood pressure regulation. See here. Now this is the normotension, okay, normal blood pressure. Okay, normal blood pressure, and all these factors should be in balance, then only the blood pressure will be normal. Now let's talk one after other. What happens in case of increased blood pressure? How the body will regulate the blood pressure? Okay, let's talk about this. See there, in increased blood pressure, the cardiac volume sensors will feel that, and there is release of atrial natriuretic peptide from the right atrium. Especially in case of hypervolemic condition or excessive blood volume, this ANP would be released by the right atrium. Please mute yourself. By the right atrium. Okay, now what will happen? This ANP has a different functions or mechanism. Okay, I muted all of you now for certain time, then I'll unmute again. Let me explain this first. So this ANP is released from the right atrial wall, and there are certain functions of this ANP. You can see it clearly there. The two important functions which are shown here are: one, it excretes the excessive sodium that is collected in the blood. Okay, see there, it excretes sodium. Along with sodium, water is also excreted. This is how it is decreasing the blood volume. And when blood volume is decreased, blood pressure is also decreased. This is one mechanism of atrial natriuretic peptide. Another mechanism is it can also lead to vasodilation, but this is not the major mechanism. The major mechanism is the first one. Both of this is trying to bring the blood pressure back towards the normal. Now blood pressure has been fallen, isn't it? Now what is happening to the body? Let's talk about it. Now when there is decreased blood pressure, there is decreased renal perfusion. Now that is sensed by the renal pressure and sodium sensors, and after that renin will be released. After that renin will be released. Now this renin will lead to conversion of angiotensinogen into angiotensin 1, and angiotensin 1 would be converted into angiotensin 2 by ACE enzyme. Okay, ACE enzyme inside the capillaries of the lung, and angiotensin 2 is formed. Now this angiotensin 2, okay, is having different function. I have already explained this. It causes vasoconstriction, can directly raise the blood pressure, or it can lead to secretion of aldosterone, which is resorbing sodium and water. By that it increases the blood volume, and again blood pressure will come back towards the normal. So this is how the balance is occurring on our body. So all of these are called compensatory mechanism. Now one important question, I always ask this question to the student: if compensatory mechanisms are so good, then why we develop hypotension or hypertension, isn't it? And the answer is, if those causes are continuously happening or persistently occurring, then they overwhelm this mechanism. This mechanism cannot function forever in the same way, and that's how we get the pathology. Now with this, let's talk about essential or primary hypertension. Okay. Now, what are the mechanism of essential and primary hypertension, and what are the important points? Now, this is also known as idiopathic hypertension because the exact cause is not known, but there are certain factors or certain hypotheses we know. So let's talk about this. One is a genetic factor. So it runs in the family. There is a strong family history for essential hypertension. And another fact is also proving the same thing. It has a high chance of occurrence in the twins. This is called concordance rate. If one twin is affected with essential hypertension, another twin has also high chance of having the similar type of illness. Okay, the concordance rate is high. Another is racial and environmental factors. Now, incidence of essential hypertension in African and American is more than in the white. This is the difference in race. And salt intake, obesity, higher living standard, and individual under high stressful situations are having more chance of essential hypertension than other. See there, salt intake, obesity, higher living standard, okay, and individuals under high stress. All of us know these are the important risk factor for hypertension, and they are also mentioned here. But exactly how they lead to this, primary hypertension is not known. That's why it is written the cause of essential hypertension is still unknown. Now, the pathogenetic mechanism in essential hypertension is explained by different theories. Okay, these are the theories. They are high level of catecholamine, norepinephrine and epinephrine, increase in blood volume and arteriolar constriction, and increased cardiac output. So just analyze these things together. Catecholamine is a powerful vasoconstrictor, as well as it causes contractility of the heart, and it increases the heart rate also. So all these things will increase the blood pressure. Increase in blood volume will increase blood pressure, and cardiac output definitely will increase blood pressure. So all these things will cause increase in blood pressure. Now, in the next slide, we'll talk about some hypothetical scheme for the pathogenesis of essential hypertension. And this scheme tells us there are certain genetic defect in the renal excretion of sodium. So rather than excretion of sodium, our kidneys are probably resolving that sodium into the blood. And by doing that, it is, increasing the blood volume. That is one. And at the same time, if the person is taking excessive salt in the diet, okay, all these things will be potentiated. All these things will be, increase in the reaction. Now, let's see what are the important points here. Okay, so all of you, please pay attention here. Now, see here, these are the genetic defects. Genetic defects is the first thing which we will talk. Okay, genetic defect or genetic influence is the first one, and these are the different things occurring because of genetic influence or defect. Defect in renal sodium homeostasis, functional vasoconstriction, and defect in vascular smooth muscle growth and structure. Okay, the end point is important here. Okay, let's continue to analyze and let's reach the end point, then it will be very easy for you to understand. Because of the defect in renal sodium homeostasis, okay, see there what is happening. There is excessive salt and water retention and inadequate excretion of the sodium. This will lead to excessive plasma volume. This is extracellular fluid volume. Okay, plasma is one of the type of that, leading to increased cardiac output. Okay, now some of the autoregulatory mechanism will try to bring this back towards the normal. We know that, and one of the important autoregulatory mechanism is here. There is increased secretion of natriuretic hormone. But if this continue to happen, this autoregulatory mechanism is overwhelmed. It cannot. It become weaker in comparison to this mechanism. You understand like that. Now, another one is functional vasoconstriction. which results in increased vascular reactivity, and that can easily lead to increased peripheral resistance. And another one, defect in vascular smooth muscle growth and structure, which is also causing increased vascular wall thickness. So it will again lead to increased resistance. On the one side, we have increased cardiac output. On the other side, we have increased peripheral resistance. Both of these will lead to hypertension. So this is the hypothetical sequence, what we believe is happening in case of essential hypertension. Now, with this all important types of concept, let's move on to the hypertensive heart disease. What are the effects of this persistent hypertension on our heart? This is called hypertensive heart disease. Now, this is also known as systemic left-sided hypertensive heart disease, because the systemic hypertension which we are talking right now is damaging the left side of the heart. At the end of this topic, I have also included pulmonary arterial hypertension, and we'll talk that separately. Now, some diagnostic criteria are there for the hypertensive heart disease on the left side, and these are a history or extra cardiac anatomic evidence of hypertension should be there. A history of hypertension is provided by the patient. We ask this question and patient say, yes doctor, I am having increased blood pressure for the last 10 years and I am taking medicine. That's a very good point for the diagnosis. Another one, extra cardiac anatomic evidence of hypertension, maybe kidney disease, maybe eye problem or the retinal problem, maybe or some stroke in the past or something like that. Anything. That is the important point. Second, left ventricular hypertrophy is typically of concentric type. Absolutely important point. I already told you this is a pressure overload condition, and in pressure overload condition, the hypertrophy is of concentric type. That means it is growing towards the chamber of the left ventricle. Ultimately, it will make the left ventricular chamber narrow. The third point, absence of other lesion that induce cardiac hypertrophy like aortic valve stenosis and coarctation of the aorta. These are also pressure overload situation. They can also produce the same type of problem in the wall of left ventricle, so that should be absent. So how can we confirm they are absent? By doing echocardiography. Echocardiography is the one of the most important investigation for heart disease. You can also go for ECG in certain situation. Now, what are the morphological features in systemic left-sided hypertensive heart disease? So let's talk about it now. Left ventricular wall is thickened by more than 2 centimeter. This is important point. Normally it is 1.2 to 1.4 centimeter, but because of hypertrophy it is more than 2 centimeter, and the weight of the heart is increased. It has become more than 500 gram now. Normally it is 320 to 360 gram. This is just a theoretical importance. Practically, if you see the wall very thick, yes, that's enough for us, and if you measure, it would be more than 2 centimeter. Another one, myocyte and nuclei are enlarged. This is a microscopic appearance. Myocyte, we're talking about cardiac myocyte or cardiac muscle, and nuclei are enlarged because of the hypertrophy. In long-term disease, over a period of time, there is diffuse interstitial fibrosis and focal myocyte atrophy, as well as degeneration. Some of the myocyte will die away. There is impairment of diastolic filling, and now because of the reflection of pressure backward, there is left atrial dilation as well. I told you this point so many times. Because of the because the chamber size is getting smaller, it will cause impairment of diastolic filling, and the pressure would be reflected backward now. So left atrium is affected first, and still beyond that the pressure would be reflected. So pulmonary vein is affected, pulmonary capillaries are affected, and there is a high chance of pulmonary edema. Left ventricular chamber dilation and wall thinning lead to heart failure. Okay, when this hypertrophy change into dilation, then heart failure occurs. Remember, in case of heart failure, or even in case of physiology, when we're talking about cardiovascular physiology, there is one thing called Frank Starling law. Frank Starling law. That Frank Starling law says, in the beginning, because of any a prolonged type of stress given to the heart, this is a stress, it will lead to hypertrophy. It will lead to hypertrophy, and it will cause increased work of the heart, but it cannot do like that forever. Okay, everything has got a limit here. So this is also known as rubber band analogy. You can only stress the rubber band up to a certain limit. If you exceed that limit, it will break. The same thing applies here. For a certain period of time, this hypertrophy is good for the heart, but if the etiology is still the same, if it's still hitting the heart like that, then after some time that hypertrophy will change into dilation and the failure of heart occurs. Okay, so this is a very important concept. Now look at this picture here. This is a very good picture to explain everything whatever we have studied till now. So let me explain this. So here there is a marked concentric thickening of the left ventricular wall, causing the reduction in lumen size. Look at this. This is left ventricle. See here how thick is the wall. This is the free wall of the left ventricle. This is interventricular septum, and both of these are so thick that the lumen is getting narrow. And you can see a pacemaker which is kept here. This is a pacemaker. Okay, this is a different thing. This is not related to our topic at all. And another thing, look at this chamber now. This is called left atrium. Because of the stiffness of this chamber, all the pressure would be reflected backward, and left atrium is dilated. It is a very thin walled chamber, so it cannot have hypertrophy. It is dilated very early in the process. So this is a very good, real pathological specimen which is showing a concentric hypertrophy of the left ventricle and dilation of the left atrium. Now, what are the clinical features of left-sided hypertensive heart disease? In the beginning, the patient may be asymptomatic. Patient may present with atrial fibrillation because left atrium is dilated. Okay, that dilated left atrium can easily develop atrial fibrillation. This atrial fibrillation means atria is not contracting normally, it is just fibrillating. Okay, the contraction power is not there at all. This is how you remember. Congestive heart failure is a common manifestation. Sudden cardiac death can happen. Suddenly a ventricular arrhythmia arise and the patient may die. Renal failure may occur, and this is the effect of the hypertension, and stroke can occur, again the effect of hypertension. So these are the different clinical features. Now after this, let's move on to the pulmonary hypertensive heart disease, also known as cor pulmonale. Pulmonary hypertensive heart disease or cor pulmonale, absolutely important topic, so please pay attention. Now the definition of cor pulmonale is it consists of right ventricular hypertrophy and dilation, frequently accompanied by right heart failure, which is caused by pulmonary hypertension that is attributable to primary disorders of the lung parenchyma or pulmonary vasculature. So what do you mean by that? Let me explain. Yes, there is right ventricular hypertrophy or dilation, and many of the time that right heart has failed. There are features of failure of right side of the heart like raised JVP, hepatomegaly, this is also known as congestive hepatomegaly, ascites, and pedal edema. These are the four most important features of right sided heart failure. But what is the cause of that? The cause is from the lung. This is important one. Okay, cause is mostly from the lung or from the pulmonary blood vessel, and that is pulmonary artery. So let me say it once again. Chronic disorders of the lung parenchyma and pulmonary vasculature disorder can lead to pulmonary hypertension, and that pulmonary hypertension is causing right ventricular hypertrophy and dilation, leading to right sided heart failure. This is called cor pulmonale. Sometimes, okay, sometimes even the chest wall pathology can also lead the same. Now, right ventricular enlargement due to congenital heart disease or left ventricular pathology should be excluded for the confirmation of the diagnosis of cor pulmonale. What do you mean by that? See here. Right ventricular enlargement or failure can also be caused by other diseases like congenital heart disease or left ventricular pathology. In the morning class, I clearly talked about this. Okay. Let me describe it once again, like mitral valve disease, MS or MR, or even AS or AR. How they cause failure of the right side of the heart. Okay, what they do, they develop back pressure. That back pressure is reflected on the left atrium first, then onto the pulmonary vein, then pulmonary capillary, then pulmonary artery, then the right ventricle. So that's the connection. Okay, long connection actually, but possibility is there. Ultimately, right side of the heart fails, but it is never known as cor pulmonale. It is known as failure of the right side of the heart by the left side of the heart pathology. Now, cor pulmonale can be acute in onset, as with pulmonary embolism, or insidious in onset when, due to prolonged pressure overload in the setting of chronic lung and pulmonary vascular diseases. So acute in onset or acute cor pulmonale is caused by pulmonary thromboembolism. Okay, very important condition. It may cause sudden death in the patient. And chronic type of cor pulmonale occurs in a disease like COPD. Okay, COPD is the perfect example here. Bronchiectasis, okay, cystic fibrosis. These are the important conditions. Now, the time has come for us to discuss the causes, okay, to discuss the causes of, okay, so let's move further. The causes are, let's talk about the causes of cor pulmonale. The causes can be divided into different headings. Diseases of the pulmonary parenchyma, disease of the pulmonary blood vessels, disorders affecting chest movement, and disorders inducing pulmonary arterial constriction. The first two are the most common, of course. So let's list what are those. Now see here, diseases of the pulmonary parenchyma. They are chronic obstructive pulmonary disease, COPD, chronic bronchitis, and emphysema. They are the top on the list. They are so common in general population, and both of them are caused by smoking mainly. Okay, and they are very common in the older age. After the age of 50 or 55, these diseases are quite commonly developed. Sometimes even the younger patient can develop chronic bronchitis. Now, one very important question your teacher may ask you: what is the mechanism of cor pulmonale in COPD? Okay, now listen carefully. The mechanism is slightly different than how left-sided heart disease cause right ventricular failure. Mechanism is slightly different. Now, COPD causes hypoxia. Hypoxia leads to pulmonary vasoconstriction. This hypoxia is a chronic type of hypoxia. So chronically there is vasoconstriction inside the lung. Now vasoconstriction means increased resistance in the pulmonary artery. That resistance is reflected on the right ventricle. Now everything else after that is same. Right ventricle will start to hypertrophy, later on dilate, and this condition is known as cor pulmonale now. Okay. Diffuse pulmonary interstitial fibrosis, same mechanism, it also causes hypoxia. One of the good example is here is idiopathic pulmonary fibrosis. Pneumoconiosis is dust related lung disorders. Dust related lung disorders like anthracosis, okay, anthracosis, silicosis, berylliosis, okay, asbestosis, all of these known as pneumoconiosis, because if we inhale this type of dust for a long time, they can badly damage our lung, and the type of damage is fibrosis of the lung. Cystic fibrosis is a genetic disease. It's a genetic disease which can cause bronchiectasis in the lung, and bronchiectasis is a chronic lung disease which again can lead to cor pulmonale. See there, bronchiectasis is written separately because there are other causes of bronchiectasis as well. Cystic fibrosis is just one of them. Now the second types of disorders are disease of the pulmonary blood vessels, and they are recurrent pulmonary thromboembolism, small type of thromboembolism. If they are repeatedly blocking the pulmonary blood vessels, then that can also create increased resistance to the right side of the heart. Okay, over a period of time it may develop into cor pulmonale. Primary pulmonary hypertension. Now from the birth itself, okay, from the birth itself, the pulmonary hypertension has excessive pressure, means it is already narrow, the lumen is already narrow with the tunica media layer is thickened. So what does that mean? The right ventricle is having excessive pressure from the early phase of life. This is primary pulmonary hypertension. Disorders affecting chest movement is the another one, and these are kyphoscoliosis, marked obesity, and neuromuscular disorders. Now see there, kyphoscoliosis, okay, you know, kyphosis, okay, is backward bending of the vertebra, but the patient's position is, it look like a patient is bent forward, okay, patient is kneeling forward, but if I talking about the curvature of the vertebra, it is bent backward. Kyphosis. Scoliosis is on the side. The combination of that, kyphoscoliosis. Marked obesity, there is deposition of fat everywhere, so expansion of the chest wall is a problem here, so it can result in hypoxia. And neuromuscular disease are also the same, okay, again the muscles are paralyzed, okay, then the expansion of the chest is not good. So all of these can be some of the factor for cor pulmonale. Now another one, disorders inducing pulmonary arterial constriction. Disorders inducing pulmonary arterial constriction. What are those? Metabolic acidosis. Definition wise, metabolic acidosis means pH is low, bicarbonate level is also low, okay, and carbon dioxide level may be normal or slightly low. There is no connection with carbon dioxide level in metabolic acidosis definition. Only we are concerned with pH and bicarbonate. Hypoxemia, very important factor which cause constriction of the pulmonary artery, and this is the main mechanism in COPD and pulmonary parenchymal disease. Chronic altitude sickness. Now high altitude is the area where there is relative hypoxemia or relative hypoxia, okay, the tension or the pressure of oxygen is low there, so people are relatively hypoxemic, and these hypoxemic people are polycythemic as well. Over a period of time, what is the reaction of this hypoxia on the pulmonary blood vessel? Same thing, vasoconstriction. Obstruction to major airway, again because of vasoconstriction, because of hypoxia, there is vasoconstriction of the pulmonary artery. So very easy to explain. Remember hypoxia here. This is very, very important term for the description of pathogenesis. Now we are moving towards the end of this topic. What are the morphology of cor pulmonale? How it looks in acute cor pulmonale and chronic cor pulmonale, and what's the difference between them? Now in acute cor pulmonale, remember it is caused by pulmonary embolism. Now a little bit about pulmonary embolism here. The common source of pulmonary embolism is from deep veins of the lower limb. They suddenly get detached and they are moving towards the right side of the heart. There is right atrium, right ventricle, and from there through the pulmonary artery they go towards the lung. Now it all depends on the size. If size is big, okay, now it will lodge right at the bifurcation of pulmonary trunk like a saddle. So this is called saddle thrombus, and this saddle thrombus can kill the patient quickly. Just think about the situation here. No blood is going towards the lung because of complete obstruction by the saddle thrombus. The person will die because of hypoxemia. Okay. Now this condition is known as acute cor pulmonale. So what is the morphology? The right ventricle usually shows only dilation. There is no time for the hypertrophy. If an embolism causes sudden death, the heart may even be of normal size. So it all depends on the duration. If duration is longer, then only a hypertrophy develops. If duration is short or there is no duration at all, for example, sudden death happens in the patient, the chamber of the right ventricle can even be normal. Now, what about chronic cor pulmonale, which is more common than the acute one, much more common actually, okay? So it is characterized by right ventricular and often right atrial hypertrophy, because there is a lot of time now, so hypertrophy can occur easily. In extreme case, the thickness of the right ventricle wall may be comparable with or even exceed that of the left ventricle. This is important one. Okay, so right ventricle is as thicker as the left or even more than that. In normal people, it is never like that. Right ventricle is a thin wall than the left, but because of the cor pulmonale, it may happen like that. Now see here, right ventricular hypertrophy, okay, more than or equal to 1 centimeter. In late stage, even dilation can occur. And when dilation occur, all the features of right-sided heart failure will be there. Tricuspid regurgitation can occur due to dilated right ventricle. Very easy concept. If the ventricle is dilated, there is a gap development between the annulus of the tricuspid valve and the inner wall of right ventricle. So blood may leak backward. This is called tricuspid regurgitation. Left-sided heart is normal here. There is no connection with the left side of the heart, and there is thickening of the pulmonary arterial wall, and even atherosclerosis may be formed. So these are the important feature of chronic cor pulmonale. Now look at this picture here. Now I am focusing on the right side of the heart. Okay. See here, this is right side of the heart. Now it is dilated already. Okay, markedly dilated. Look at how big is the chamber, and hypertrophied also. So this is called cor pulmonale. Okay. At the end, please go through these questions and solve them.